Okay, we're going to jump right into chapter 14. This is going to lead into more of those hands-on types of activities, and this one focuses on assessment. Okay, this is your foundation. This is where you really need to be absorbing all of the information. In this chapter, we're going to talk about the principles of assessment, the physical exam, and how we approach that exam. We're going to talk about the body systems that we kind of break it down and look at. And with that, then we use our critical thinking to help determine what the next step should be. When we are assessing the patient, it's important to get a good history. We need some information about the patient themselves. Now, when we talk about history, understand that we need to know what's happening now or what happened before we arrived, but we also need to know about their past medical history, such as if they have a history of heart disease or if they have respiratory problems that are chronic, such as COPD. It's extremely important that you are comfortable talking to the patient. Sometimes this can be a little difficult at first, but I assure you that the more comfortable you are talking to your patient, the easier it's going to be to ask these questions, and the more rapport you're going to develop with the patient so that they trust you and they're willing to open up with information that may be embarrassing or very personal. So with the history taking, we're going to be talking to the patient and asking lots of questions. If the patient's unable to respond to us, meaning they're too young to understand and answer our questions, meaning they're unresponsive on the floor, we kind of look to the next option, and that's really going to be those family members. It may be a spouse, it may be a parent, but utilize those individuals that are present to get some information about the patient, not just what happened, but what's happened in the past and their past medical history. Bystanders may have some information that they can share with you, maybe a neighbor. We also need to look around for medications. If we see medications, what are they? Do they have the patient's name on them? Insulin is kept in the refrigerator, so if we have the potential for a diabetic, check the refrigerator, see if there's insulin in there. Other things that we observe at the scene may include drug use, may include alcohol, may include a blood pressure cuff, or anything medical related that could tell us of a potential underlying condition. Really focus on developing that rapport with the patient. We want the patient to trust us, and we want the patient to feel that we are compassionate and confident in doing what we need to do for them. Ask open-ended questions. What we mean by open-ended questions is, don't say, did you have pancakes for breakfast? Yes or no. That's a closed-ended question. An open-ended question would be, what did you have for breakfast? Pancakes, eggs, sausage, right? That leaves the question open for them to answer any which way. We try not to lead them to an answer. So these open-ended questions really do help. And it may spark another question in your mind to continue up that conversation. Now, closed-ended questions are going to be appropriate if we need an immediate answer or if the patient is having difficulty communicating with us. History taking is really going to help us with getting the whole picture. We need to know what's happening with the patient, but understand that sometimes a chronic condition or an underlying condition may have led to what's happening right now. We're going to talk about mnemonics in EMS, and mnemonics are just techniques to help you remember things. So when we talk about history taking, we use the mnemonic OPQRST. That should be pretty easy for you to remember, but each of those letters stands for something. Onset means, when did this begin? What were you doing at the time of onset? Provocation. What potentially makes this worse? Or what makes it better? I had a headache, I took Tylenol, it made it better. Quality. Tell me about the quality of the pain. Really describe it. Is it sharp? Is it dull? Is it cramping? Is it burning? The region where it's at and radiation are going to be important because we are identifying where this has occurred on the body and if it moves. Sometimes pain will radiate. So although you're having a problem with your knee, it may hurt all the way up to your hip. Severity is giving it a number. We like to have patients rate their pain on a scale of 0 to 10. 0 being no pain, so a lot of times people will say 1 to 10, but 10 being excruciating pain. Have them rate their pain. That way we can trend that. We can look at that information later on our time with the patient to determine if it's getting worse or getting better. And then time. We're looking at the time of the onset and how long this has been going on. Are we talking minutes or days? Another mnemonic I want to introduce you to is sample. Sample is going to give us information about the patient's history. So OPQRST deals with the HPI and what is happening right now. The sample history deals with past medical history, and sample stands for signs and symptoms, allergies, medications the patient takes, pertinent past history like open heart surgery, high blood pressure, diabetes, last oral intake, when was the last time they had something to eat and or drink. And then we like to identify the events leading up to the injury or illness. What happened just prior to this all beginning? Depending on the age of the child, your interviewing technique may change just a little bit. So when we're dealing with children, preschool children can be interviewed with simple language, maybe some yes or no questions, but make sure that they're comfortable. So we want to have a parent there. We want to have somebody they know there, maybe even allow them to sit on their lap until we get some more information. School-age children can describe what they're feeling pretty well. So have them point to what hurts. Have them tell you, is it squeezing and make a fist? Let them describe it in their words. But again, always have someone there so that the child feels comfortable. When we do our physical examination, this is really going to be continuous. So your OPQRST and your sample are going to occur when you first arrive on scene and begin, meeting and dealing with the patient. There are other aspects, though, that will be almost fluid or continuous, and that is the physical exam. We begin to do it before we even touch the patient, before we even talk to the patient, but it just builds off of that. So the three primary techniques that we really look at is observe or inspect. This is where we're looking at the patient. We're just visualizing how the patient looks. Skin color, skin condition. Do they look sweaty? Are their eyes open? Are they sitting upright? Do they look like they're struggling to breathe? And then we start to use our stethoscope and we listen. We're going to be listening for normal or abnormal sounds, especially with the heart and the lungs. Palpate is what we call touching. And so this is where we are actually placing our hands on the patient and we are feeling for abnormalities or deformities. Here's a quick image. Just at a glance, what do you see? I see a gentleman. His skin color looks okay, but I can see he's wearing a nasal cannula, providing him some supplemental oxygen, and he's got his hand on his chest. This could be a sign for chest pain. This could be a sign for trouble breathing, but it's not usually a good sign. Okay, let's talk about the pediatric physical assessment. Be careful when you're approaching these children. You are a stranger, and kids are taught stranger danger. Kids also see what's on the media, and sometimes people in uniforms are not always seen in such a positive light. So be sure you're telling them who you are and why you're there, that you are there to help them. Begin with the least invasive parts first. That means we're really going to start at their toes or even at their trunk by their belly. We're going to work their way to the head until we can kind of develop that relationship with them. As we get to the head, understand we're probably going to be quite a bit closer to the patient so that we can inspect better. Explain all of your equipment to the child. Most of them have seen a stethoscope before, but tell them what you're going to do with it. And never lie to the child. If something is going to hurt, tell them it's going to hurt. If they have an injury and we are going to splint that injury, it's probably going to hurt at least until we get it splinted. So let the patient know that this is going to be uncomfortable and have them squeeze a pillow or a stuffed animal to help them through that process. And always, always respect their privacy. Children can range from being very modest to not. So we want to make sure that their privacy is always respected. If we have to expose something, make sure that we are in a private area in which to do that. Make sure that if we are asking them a lot of questions, that the people around really need to be there and be part of the patient care. Okay, we're going to start breaking it down into body systems. First off, the respiratory system. This is really one of the most important systems that we need to assess. And that's because we know that the breathing and the circulatory system go hand in hand. If the patient is not breathing adequately, we're going to have some major problems. Remember I said that assessment really is pretty fluid. So we're going to get the history of their existing respiratory condition and what's going on. We're going to see what medications they take, how have they been taking those medications, and the signs and symptoms of this episode, what is happening. But while we are asking those questions, pay close attention to the way that your patient answers. Are they very short of breath? Do they have to take frequent pauses in order to catch their breath a little bit more? So your respiratory assessment goes a little bit further than just watching how they breathe. We also have to look at their mental status. How alert are they? Remember, we talked a little bit about hypoperfusion, and if they're not getting the oxygen that their brain needs, then they're going to act different. Their level of respiratory distress. Are they gasping? Are they leaning forward? Do we hear anything audibly? Do you hear wheezes? Is the patient coughing? Those are all going to be concerning signs. What about chest wall motion? Do we see rise and fall of their chest? Do we see funny movement in their chest? Then we want to listen to the lung sounds, auscultate lung sounds. We're going to do this in a couple of different areas, and we're listening for anything that sounds unusual or abnormal. I will tell you that in really poor situations, the patient may not have any lung sounds. Use a pulse oximetry. This tool is there for our use. Now we aren't going to rely 100% on it. We need to put the pulse oximetry reading with what our assessment is showing and how the patient looks to determine how serious the situation is. Observe for any edema, and if the patient has had a fever, this is going to be important to note. Dealing with the cardiovascular system, we have the heart, the blood vessels, and the blood that's in there. So cardiac patients and patients that are in shock, we should be able to identify that vascular problem. They're likely to look pale. They're likely to have an increased heart rate. and they may even have a decreased blood pressure. As we get their cardiac history, we want to know cardiac conditions that they have been diagnosed with in the past. We want to know any medications they take for those conditions. What signs and symptoms are they having now? And then use our OPQRST to describe pain. So if we're having chest pain, how do they describe it? Determine specific characteristics of that discomfort. Does this feel like anything you've ever experienced before? If so, what was going on during that time? As we go through our cardiovascular system, understand that again, this is a system that could indicate a life-threatening issue. So pay close attention to those signs that you may see. Get a pulse, get a blood pressure. Note the pulse pressure. That means the gap between your systolic and diastolic numbers. Look for jugular vein distension, or JVD. Palpate the chest. As you palpate the chest, we're feeling for any abnormalities. We're listening for the patient to complain of pain when we touch. And as you're palpating the chest, you should also feel the chest rise and fall with their breathing. Is there anything abnormal about that? What posture is the patient in, or what position does the patient prefer to be in? Remember, when you lay flat on your back, it's a little bit harder to breathe, especially if you're overweight. So patients are likely going to want to sit up if they're having some respiratory issues as well. Dealing with the nervous system next, we're looking at the mental status of the patient and signs of dysfunction in the body. Is the patient unable to control a certain side of their body, their legs, their arms? The nervous system helps us to use our muscles, and so we're looking for abnormalities there. Let's identify the patient's mental status. We use the mnemonic AVPU: alert, verbal, painful, unresponsive. Determine the patient's normal state of mental functioning. Remember, everybody is different, and if we're dealing with someone who looks older but they're not speaking, maybe there's some type of delay, or maybe there's some type of altered mental function that was known prior to this event that we are now dealing with. Get a history of neurologic conditions if the patient has had a history of a stroke or an aneurysm. And note the patient's speech. Speech is typically clear and easy to understand. We know that if the patient is younger, maybe they're just developing speech. We know if someone is intoxicated with a substance, maybe they're slurring their speech, or they're not able to put sentences together very well. Look at how the patient is talking, and that will help to identify potential problems as well. With your neurologic exam, it's important that you assess a little bit of everything, and so checking for sensation and movement is going to be important, especially with those lower extremities. By sensation, can you feel me touch you? And movement, wiggle your toes. Anything like that will work. Performing a stroke scale is the Cincinnati stroke scale, and that is where we're going to look at any facial droop. We're identifying if they have any slurred speech, and we're going to have them do a little bit of a test where they hold their arms out straight in front of them and close their eyes. Arm drift will occur if the patient has had a stroke, and it will indicate the side of the stroke. Gently palpate the spine, again, feeling for abnormalities or the patient to complain of pain or discomfort. Check the extremity strength. I understand that most of us have a dominant side, but we're just kind of looking to make sure both sides are working and we don't have paralysis of one side. Check the patient's pupils. Again, the pupils are kind of our window to the brain. We're looking for equal pupils, and we're looking for both pupils to be reactive to light. Check the patient's gait. This means if they're up and walking, what do they look like when they're standing up? Are they trying to follow the wall? Are they holding on to something as they're there? Not every patient is going to be standing up walking for us, but if they are, this is a chance to get some more information to add to our assessment. The endocrine system is a very important system. However, in EMS, we don't run into too many endocrine type emergencies. The big one we're going to deal with is going to be that with a diabetic patient, dealing with issues of hypoglycemia, low blood sugar, or hyperglycemia, high blood sugar. As we're talking with the patient and identifying their past medical history and medications, we want to identify if they are diabetic or if they have any type of thyroid disease. Are they using any medications to help manage these conditions? If they are, when was the last dose? Are they taking it as prescribed? Ask if the patient has eaten or exerted a large amount of energy, because if the patient has or has not eaten, or if they've exerted energy, is going to affect their blood sugar. And if they're diabetic, this is going to be important. If the patient is sick, the body works a little bit differently as far as insulin production. So ask the patient if they have been ill recently. And with that, have they been having any vomiting and or diarrhea? We need to know if the patient has taken blood glucose or if they use an insulin pump. These things are important because we may not see them readily in front of us. A patient with an insulin pump likely has it tucked underneath their clothing somewhere, and so it's important to identify if they have it. As far as your evaluation of the endocrine system, we're going to look at the mental status. We're going to identify the patient's skin condition, pale, or if they feel moist, clammy. We want to get a blood sugar or a blood glucose level. This is really important in all of our patients, but extremely important in a diabetic. Look for an insulin pump. Again, if the patient is unable to tell us, then we may have to kind of pat the patient down, feel and look for one. Maybe a family member or bystander will be able to help us out with that as well. And look for medical jewelry. We don't see individuals wearing the Medic Alert bracelets as often as we used to, but they do make Medic Alert bracelets and necklaces. So look at your patient to see if any of these are in place. The gastrointestinal system is dealing with the stomach, so we're looking for what the patient has recently consumed and has that come out. Are they having vomiting? Are they having diarrhea? If they are, what does that look like? When there's blood in vomit or in stool, it's going to have a different appearance than just looks like the food you ate just chewed up. As we assess the GI system, we want to identify if there is pain or discomfort in any area of the abdomen, the oral intake that the patient has had, and this is not just food, but also liquids. Do they have a history of any gastrointestinal issues, such as IBS or Crohn's? Vomiting, and then bowel movements. Now, as we are assessing the GI system with our patient, we want to note their position. Many patients with GI complaints will be curled up in what we call the fetal position. So kind of with their knees drawn up towards their abdomen or their chest and on their side. Assess the abdomen. Remember that assessment includes 3 pieces. And in the field of EMS, we really only look at 2. We want to inspect or observe. We're looking for any discoloration or bloating, bruising, or other signs of obvious problem. And then we want to palpate. When we palpate the abdomen, we want to do that gently in all 4 quadrants, identifying any area where the patient feels pain, or if you feel an unusual lump or mass underneath your hands. Inspect other parts of the gastrointestinal system. This may mean you're looking kind of to make sure their throat is normal, the trachea is midline and all of that. You're looking at their mouth and their nose. You don't necessarily need to go much further than that, but we do want to identify if there is any potential problems with that upper part of the GI tract. If there is vomit or feces, then take a look at it. A lot of patients will save it for you, and I know that that sounds horribly disgusting. However, if we look at it, it can give us a lot of information, such as if it looks like just undigested food, if it looks like there is blood in there, if it's made up of mostly mucus. These pieces of information are going to help in the long term as well to diagnose the patient. With the immune system, we're dealing with those allergic reactions. In EMS, it is mostly anaphylactic reactions, and these are the severe allergic reactions individuals may experience. Let's find out if they have any allergies. Remember, allergies are part of our sample history. Have they had any exposures to those allergens? And what is the typical reaction when they are exposed? If the patient has ingested something, understand that the reaction may continue to get worse. If it's something that the patient was exposed to because it brushed against their skin, then hopefully the reaction is not going to be extreme, but we still need to watch out for the anaphylaxis reaction. Do they have a history of asthma? Many times allergies and asthma go hand in hand, so they may have both. Symptoms of tightness in the chest or in the throat. Individuals may state that it feels hard to breathe or hard to take a deep breath. You may even hear whistling or wheezing. GI distress, itchiness, or a rash. They may feel nauseous, they may vomit or even have diarrhea. Itchiness, they may have a rash with this or not, but typically the itchiness is going to occur where the exposure occurred, unless this is something that again was ingested or inhaled. Then the individual may have a systemic reaction with a rash and itching, and that could be all over. What medications are available for allergic reactions? What medications does the patient use when they have an allergic reaction? Again, we want to identify how the patient was exposed to the allergen, and we want to inspect that area. Inspect the patient's rash. Inspect the face, lips, and mouth. If the patient is having swelling of the face, lips, and mouth, this is called angioedema. And because of the swelling of this soft tissue, it can actually cause the airway to close off. So that is going to be an emergency for sure. Listen to the patient speak. If it sounds very muffled, if it sounds tight, it's hard to get the air through, we should be able to identify that. And don't forget to auscultate the lungs. We want to auscultate the lungs to make sure that the patient is adequately breathing, and hopefully we have can identify wheezing or other abnormal sounds. Musculoskeletal system issues. So most musculoskeletal system diseases are not going to be calling EMS. It's going to be rare that we see them. However, it is important that we do a full exam on everybody. And many of the musculoskeletal exams are going to be performed as part of a trauma examination. With musculoskeletal systems, it's important to know what the patient's normal is, so that if we're asking them to move a body part or can you feel me touch this, we know that this isn't a deficit that they've had chronically. So what are the patient's prior injuries? Whether the patient takes any blood thinning types of medication is going to be important for those with musculoskeletal injuries. Even if it's a blunt object that has struck them, something flat that didn't penetrate the skin, they can have a great deal of internal bleeding if they are on these medications. Underlying diseases or conditions can sometimes make fractures more common, so these individuals are going to be at a higher risk. And then history determine if a medical problem caused the traumatic injury. Many times you'll arrive at an accident scene where you've got a motor vehicle collision or an MVC, and the individual behind the steering wheel that was in the accident had chest pain just prior and essentially is having a heart attack, and that's what made them crash the car. We still need to address the patient from that physical standpoint with the traumatic injuries, but we also need to take care of their cardiac needs as well. As you're inspecting the patient, we're looking for any deformities, and this includes the extremities. We want to palpate the area where this injury has occurred. We want to compare the right to the left, looking for symmetry. Be alert for crepitus. Crepitation is bone on bone kind of grinding, and sometimes this may indicate that there is a fracture there, and that fracture is actually a comminuted fracture where you've got a lot of little pieces of bone. Assess the patient from head to toe, and if there are multiple injuries, if the patient is unresponsive, we may need to do this quickly, but we've got to address the life threats first. So now let's use your brain a little bit more. Let's try to figure out what's going on with the patient, and let's use our critical thinking skills to do that, and then determine what our next course of action is going to be. What interventions do we need to do, or what can we do to help the patient maybe alleviate some of their symptoms? And when we do that, identifying where we're going to take the patient as well. So diagnosis is label for condition. We in EMS do not diagnose. However, we're giving you some information that you can put the puzzle pieces together for the big picture. So based on their history, their physical exam, their vital signs, and everything that you've gathered, we should be able to come up with an idea of what's happening. So again, with different levels of training and experience, you may have more in your thought process for these patients as far as what's happening to them. Remember, we are teaching you the basics. We're giving you something to build on. We're not telling you every single thing that's out there. So this is your basic training, and then you're going to build on that with your experience and time in the field. You're going to build on that as you get exposed to more technologies and other resources to make your job easier. Techniques are going to vary from person to person as far as really how they auscultate the lungs, which order. It doesn't really matter. We just want you to do it. However, most of your clinicians are going to work in a head-to-toe fashion, unless, of course, we're dealing with those pediatric patients or we need to make other alterations for reasons the patient states. You can see here this is a best case scenario, right? The traditional approach is going to be talking to the patient in a private, well-controlled environment in a clinic or an office. However, working in the field of EMS, we're not usually that fortunate. So we've got to be able to function in some of those very difficult situations and still be able to do the job. So we need to assess our patient. We need to think about the different diagnoses that could be occurring here. We call them differential diagnoses. Further evaluation is going to help us exclude some of those differential diagnoses to really reach that final diagnosis or the condition that we feel the patient is dealing with at this present time. We work in EMS, and so we've got to quickly rule out those life threats. If we find those life threats, we've got to quickly address them. We want to get as much information as we can from the patient, the family members, bystanders, whomever is there. But some situations are going to call for us to do our physical exam more quickly. Let's focus on ruling out the worst case scenarios first. When we talk about some of these issues that the patients may be having, remember, if they're having a cardiac or a pulmonary issue, that is going to be life-threatening. If they are having an altered mental status, we have to come up with all of the potential ideas of diagnoses that could be causing that altered mental status, and then work our way through the most serious first, trying to eliminate them. And understand that the patient may have multiple injuries, and we may have multiple patients. Here you see a patient being evaluated in the emergency department, and it says here in the little note that the atmosphere can be very hectic. While I will tell you, you're going to experience that tenfold in the field. You're going to experience weather problems. You're going to experience difficulty accessing your patient, like the patient's trapped in a car and we can't get them out. You are going to experience all sorts of interruptions and background noise that could interfere with your assessment. Try to focus and do the absolute best you can. Again, we're giving you the basics. We want you to build on the knowledge that we're providing you today. Your experience and the more patient contacts you have will improve your assessment skills each and every time. In EMS, though, we have to be efficient. We've got to be able to do our job and do it quickly because many of the patients we see are dealing with potential life threats. We do work in an uncontrolled environment, and we do have a limitation on the skills that we can do and the tools that we have to do those skills. So our ambulance is going to be stocked with some pretty normal equipment, but if you go on a critical care transport ambulance, they're going to have some different tools than what we carry in our day-to-day emergency response ambulance. We like to narrow our educational focus and really look at emergency type situations, but it is important that you have an understanding of some of those chronic conditions as well. We're going to be following some simple steps, trying to do a systematic approach with our assessment. And again, working head to toe is likely going to work best in most situations. But consider those serious conditions first and rule them in or rule them out. Remember, as part of your assessment, the first piece we need to look at are the ABCs, or airway, breathing, and circulation, because we know that those can be immediate life threats. And if there's a problem with them, we need to fix them, like starting CPR. With our assessment, with the vital signs, with the history, we're going to then come up with our diagnoses. So good for you, you came up with a diagnosis. Now what? Now what are you going to do? When we identify that diagnosis, it should help us to then identify the interventions that need to be done, or additional assessment that maybe should be done that we haven't done yet. Again, with time, your assessments will become more efficient. You will become more proficient in identifying these things. So you'll be able to recognize the behavioral patterns, the vital sign patterns that go along with some of these conditions. You will be able to narrow down your differential more quickly. You will be able to reach difficult diagnoses more quickly. And you will understand your limitations and know when you can take shortcuts and when you cannot. As you develop your heuristics, these are your shortcuts. So you're going to kind of look at things through a different lens as you experience more patient contacts. So representativeness, availability, overconfidence, confirmation bias, illusory correlation, anchoring and adjustment, and search satisfying are a few of those that are talked about in your book. So a little bit about heuristics. So heuristics are the shortcuts and the bias that we can develop. I want you to understand some shortcuts are going to be okay, but experience brings with it knowledge, and we've got to be careful that we don't kind of become jaded or we don't jump too quickly to some conclusions. So representativeness is one of those where, because we've seen a patient with similar symptoms, we're just going to throw this patient in that same category. We really need to make sure we do a full assessment. Availability is because this is easier, or this is what I have been exposed to, this is all I'm going to see, and you just kind of stay in that rut because that knowledge is more available to you. But we've got to think outside the box. Not everything is going to be common, and sometimes a respiratory issue really ends up being a cardiac issue. Overconfidence. I want people to be confident, but I don't want you to be cocky or overconfident. Understand we all have a limitation. We all need to ask for help sometimes. And so you have to understand you are not in this alone and that you have some limitations. Your confirmation bias is that you have really already developed in your mind what's going on with this patient. So you're only really looking for signs and symptoms that support that diagnosis. Your illusory correlation is, again, how do we see things fitting together? Sometimes this can be misleading, again, because of those experiences that we've had in the past. We might have two things happening simultaneously, or we might have one thing causing the other. It really takes a good EMT to break down what they're seeing and with that assessment, and then identify what's going on with the patient. Anchoring and adjustment. This is where the EMT has an idea of what's happening with the patient. They've already got this idea in their head, and it's really hard for them to break away from that. If we can get them to break away, then they make those adjustments. Otherwise, they've got their mindset, this is what it is, and everything else becomes a blur. We really need to, again, keep the whole picture in frame and think about everything that's going on with the patient. And then search satisfying is when we think, aha, I've come up with the answer, and you're probably right, and then you just stop reassessing. We need to continue to reassess, because although we might have the diagnosis, we might really understand what's happening with this patient, things can always change, and you can always get a curveball. So make sure you're paying attention, no matter how long you've been in this field. Okay, this is probably one of the reasons you are going into EMS, is that you love ambiguity. You love not knowing. You love that idea of the unfamiliar or unknown. And again, every patient's going to be different. So you might have 4 chest pains, but those 4 chest pains all have something unique about them. You need to understand your limitations of you and the technology that we have. A pulse oximetry is great, but we cannot only look at the pulse oximetry and say, oh yeah, it's 98%, my patient's fine, because those things malfunction. Realize that not one strategy works for everything, and as we move into trying to treat our patients, you might hit roadblocks. You might have to critically think your way through a situation and find another way to manage them, or another way to do what you need to do. You really need a strong foundation of information and knowledge. This is what we're trying to give you right now. Again, we're just giving you the basics, and you're going to build on that with your experience. But if you don't have a strong foundation, then you're not going to be able to build very much on that. You're not going to be able to sustain your career in EMS at any level if you don't have that foundation. Sometimes it seems like everything is coming at you at once, but really you need to organize these thoughts in your head. You need to make sure that you've got all the boxes checked, right? This will sometimes change the way you think because we need to keep an open mind. We need to always be looking for the next change that our patient's going to have. Just because we get them loaded up in the ambulance doesn't mean that now you just coast to the hospital. Your job is not over. We can learn from those around us. Sometimes that might be another EMT or a paramedic. Sometimes it might be a firefighter or even a bystander. Let's look at what's happening and understand there's more than one way to do something. And if it's working, if it's getting the job done and it's not causing any undue harm or problems, then that might be something that you try in the future. And always reflect on what you've learned. Think about, how your day went. Think about maybe what you could have done better or maybe what you did really well, and appreciate the fact that you're going to be able to do it again. So, what are some of the things that you need to remember as you move forward? And how are we going to continue to strive for those critical thinking skills? I will tell you that this is never ending, right? We are always trying to do better for our patients. We're always trying to work harder. With medical information, it's always changing. There are new medications, new technologies, new techniques, and we've got to stay up on that information. So with this vast information that we are going to encounter, we need to use it to our advantage and use it for those critical thinking situations to find the best way to handle it. So here's our chapter review. Understand that you as EMTs are going to develop your own diagnoses in the field. Our NPs, our PAs, and our physicians in the emergency departments are going to come up with their own diagnoses as well. And our logic in process of thinking through those assessments are going to be very similar in the fact that we're going to first come up with differential diagnoses and then from there rule in or out each of those possibilities. With more patient contacts and more experience, you can use some shortcuts to help you through some of those differential diagnoses and your assessment, but be careful of those pitfalls and those bias. We want to make sure that we are still taking care of the patient to the best of our ability and we're not missing anything. Review those heuristics that are listed in your chapter. Make sure that you understand them so that you can avoid them. Don't forget, as we move into your career in EMS, there are some things that you just need to make sure that you understand. You've got to have that strong foundation of knowledge. You're going to be building on that throughout the course of your career. You've got to be able to organize your thoughts. And when you go into those hectic situations, be able to approach it in a level-headed manner. Please understand your limitations and the equipment limitations. If you don't have what you need, look for it. Find something else. If you need to step back because of your own limitations, speak to your coworkers and let them assist you. Ambiguity of EMS is what makes it so interesting sometimes. Know that no two patients are the same. No two situations are the same. There's always that element of unknown or surprise out there that you're going to experience. Don't forget to take care of your patient. As you contemplate all those differential diagnoses and you get excited because, hey, I think I've figured it out, in the meantime, your patient's dying if you're not doing something. So make sure that you are moving through those assessments quickly, beginning those interventions as quickly as you can. The sooner we can intervene and provide treatment, the better outcome our patient is going to have. So don't forget, as you are assessing your patient and taking the history, use open-ended questions unless you are struggling due to age or mental level of the patient. Think about your techniques with observing, auscultating, and palpating. Remember, each body system has a specific exam technique that you're going to be using and specific things you're going to be trying to identify. And don't forget to use your critical thinking. So when we think about our history, remember we're looking for two pieces of history. We need to know what's going on now and what has happened in the past. So we want the HPI, or the history of the present illness, and then we want the medical history of their past medical conditions and the reasons they use their medications. Potentially any surgeries may also be important. So here we have a critical thinking question. You've been called to the scene of a patient with an altered mental status. No one appears to know what is wrong with the patient or what happened to cause the change in his mental status. So now we've given you that little bit of a lead in. You're thinking, lots of ideas here with altered mental status. There are many things that can cause that. After we perform our scene size up in the primary assessment, again, those ABCs, which body systems would you feel the need to examine further? We have an altered mental status patient. We know that the brain is part of the neuro system, right? So let's check the nervous system out. Altered mental status could be due to hypoxia. So let's make sure that the patient's breathing adequately. Respiratory system. Let's make sure that we've got good perfusion, and that's going to be your cardiovascular system. Also think about your endocrine system, and maybe we need to check a blood sugar. That can cause some altered mental status. Does the patient have an actual bump or lump on their head? Were they involved in some type of trauma? Because physical trauma can cause altered mental status. There are a lot of things that you're going to have to work your way through with those differential diagnoses, and again, ruling in or out based off of your further assessment.